So, Dr. Alinsod, welcome to the program, VNEW Health. Happy to have you on again. I see you are all ready for a weekend getaway. Are you already in Hawaii?
No, it's all pretend Hawaii. It's digital Hawaii, but I'm in the summer mood of being in Hawaii. So I wore my Hawaii shirt. I put the Hawaii background on. So we have a fun discussion today.
There you go. And I was funny because I was sharing with Kelly. This is from Hawaii. This is the koa with the shark's teeth. A little Arms Medical on here. Got this as a gift, and so there you go. Those are my roots of living in Hawaii, and certainly loving every chance I can to get back there. So we were chatting offline about your patients and when they come in to see you. They've got, you know, they have leaky bladder, right? And they probably have some sort of pressure that they're feeling. And so, of course, a lot of times they have been to their gynecologist, and the gynecologist says, hey, I'm going to send you to Dr. Alinsod, and he's going to take good care of you. So when that woman comes and sits in your office, she's going to fill out a bunch of forms. What are the things that you're looking for? Because you usually have them do some background about them. What are some things that if a woman is interested in coming to see you, there's probably a little bit of pre-work, or at least things that they should be thinking about, because they're going to want to answer that for you. I'd love an opportunity to kind of talk about your workup and some of the pre-work, and then sometimes I think you also have a little bit of homework for them.
Yeah, usually when a patient comes sees me, they have a couple issues. One is the most common one probably is they feel like they have a leaky bladder, and I have to ask them, what do you mean by that?
Right.
You know, and so I have to separate out the leaky bladder with activities such as coughing, sneezing, jumping, exercise, and then the leaky bladder when they have just urge all the time. They feel like they have to pee all the time. They go to the bathroom 20 times a day. They wake up 3 or 4 times a night, and they just sit down and watch TV, or they drive up the driveway or put the key in the door. And once they put the key in the door, they got to pee. They get
Right.
urged. So that's this part. And then the other part is the leakage with activities. And
Right.
sometimes they're mixed.
Right.
So I have to ask those questions first.
Okay. So anything when they're sitting in your lobby, what do you have them fill out? What are they? What kind of
Well,
questionnaire are they
I,
going
I,
to
I have a one-page form that asks a lot of questions. It's called the King's Questionnaire. I think it's King's Questionnaire 1, 2, and 3.
Okay.
All put together into one page form. It'll ask, these are the questions that a urogynecologist or a urologist will ask a patient with a leaky bladder. Not just a leaky bladder, too. Anyone who has pelvic pressure, pelvic heaviness, or they can see a bulge when they bear down coming out of their vagina. Let's see, they're sitting down and they push and they see this little round thing coming out.
Right.
Or they feel inside their vagina and say, what's this golf ball here? Or what's this spongy thing? So with the leaky bladder sometimes comes the fallen bladder or the fallen rectum. So we have the questionnaire that asks that. So if we start with the leaky bladder, it'll ask, how many times do you go to urinate in a 24-hour period? How many times do you wake up at night? And can you hold your urine for an entire movie? Can you go 4 hours? Can you go 3 hours? So we ask those kind of things. Do you leak urine when you cough, sneeze, jump, stand up, get out of a chair? Any activity-related leakage. And then we'll ask, do you get sudden urges? Are there triggers to your urge? Are you having to pee more with the use of alcohol, caffeine, fruit juices, potassium, anything with vitamin C, like orange juice, grapefruit, things like that? Does that give you urge? So we go through the whole history, and we have a whole form for it so we don't miss anything. We'll ask them things like, do you leak urine, or do you feel pressure, or are you uncomfortable when you have sex? Do you leak when you have an orgasm? Do you wake up with a wet bed? Are your underwear is your underwear soaked? Is your bed wet when you wake up? So, unconscious kind of leakage.
Yep.
And also we'll ask, is your leakage only when you're standing up? Is it when you're sitting down? Because we have to know all the different positions that cause the leakage. Is it just a structural issue? Is it the weakness of the muscles? Are you able to clench? Can you stop your urinary flow in the middle of your stream?
Right.
Tells me how strong their muscles are,
Yep.
perhaps. And so, or are you, once you start, you can't stop? Are you okay? And another thing, are you, when you watch a movie, are you sitting on the edge of the movie theater by the door? And when you drive, do you know where every toilet on the road is? Are you toilet mapping?
Right.
Yeah, it's those kind of things. Also, for the prolapse issues or the pelvic heaviness issues, are you having any urge to defecate? Can you control your stools, or do you have stool leakage also? Are you having to empty your bowels by pushing in on the perineum, the space between the vaginal opening and the anal canal? Are you having to reach inside your vagina to push your stools out? That gives me severity of their symptoms. And I think those kind of questions, just by answering the questions, you can get a diagnosis probably 80 to 90% of the time without an exam.
Right.
And at the end of that, you got to examine them, of course.
Yeah, but you get a pretty good idea. I mean, you had a telemedicine, right? Just right before the show. What are some of the things? So, a couple ways that people can come see you. Number one is they can see you just like this, right? Because it just you and I having this conversation, I could probably describe all my symptoms.
Yeah.
And you could say, okay, I have a pretty good idea of, your severity, like at how much, like what led you to want to reach out to me, where that pressure is it uncomfortable during sex, or is it just the heaviness, right? So all these little nuances that you can then pick apart. Just even in the video conference, so that's the one positive.
A lot of the patients who see me have already seen their primary care and may have had a pelvic exam. So I tell them, did you get an exam within the past few months? Did they see or feel or tell you that things were falling down? Simple things like that. And most of the time, no, or they didn't examine me very well. Maybe they came from a family practice or an internist who didn't do pap smears. And so they're the ones that I really have to examine. But many have been sent to me by their gynecologist, or they've seen a gynecologist who did an exam. And so I asked Mrs. Smith, can you send me your exam or your workup that was just done and send it to me so I'll review it? So many of them have had a pelvic exam. But the thing is, I don't trust anyone. So I go using that pelvic exam by the referring doctor or the outside doctor as my guide. And I always have to do my own exam eventually. A lot of my consults now are virtual, like us talking like this. And they usually get a form from me that I sent to them. It has all those questions I just mentioned, and it's all lined up. And then I go through it with them. I review their history, and then I will see if they've had an exam already. If they've had a doctor exam, I can review it and see that they had a prolapse or no prolapse, fallen bladder or no fallen bladder. And so I go with what they give me. But then eventually, before I recommend any kind of therapy, usually I need to examine them first.
Sure.
So they will, from the virtual exam, they'll come to my office and do a real physical exam before they actually do any kind of treatments or procedure.
Yeah, so physical exam, they're gonna come in. What can they expect as a patient?
Well,
Besides
if
your
they've
amazing
had
staff, which is going to take very good care of them.
Yeah, it's pretty basic. If they've had a kid before, had vaginal birth, have had pap smears before, and most of the people with prolapse and leaky bladder are not teenagers or in their 20s. Usually their average age is 40 or 50. I just looked at all my statistics. My average age for pelvic repair and prolapse repair and even leaky bladder repair is average age of 54, at least in my clientele.
Okay.
And so those patients, they've been through an exam before. So I'll tell Mrs. Smith, Miss Smith, I'll go ahead and examine you now. And so what I usually do is I put them on a table and put their ankles in the stirrups so they're comfortable. They can keep their shoes on and all that. It's very comfortable. The room is warm. The table usually is warm, and we have a drape over them. And we have a speculum that's also warm and not cold. We don't want to shock anyone. And I only use typically half the speculum, the bottom one. So it's not painful.
Right.
It's just the half of a speculum. I place it in gently, and then I push down and I look at the bladder. So I look at the top by pushing down on the speculum, and I ask him, Miss Smith, can you cough? Bear down, push. And I sometimes will see this bulge coming out, and that's the bladder typically.
Okay.
If I have the thing down here protecting the rectum,
Right.
the only thing that can come out will be the bladder or the top of the vagina or the cervix. Then I flip the speculum around. I pull up
Yep.
and I look at, and then I ask them to bear down again. And if there's a bulge, it's usually the rectum that comes out, or the uterus, or a small bowel that comes out. So I have to identify each compartment separately, and that's an exam that all the ladies who have these problems should get. If you have a doctor that did not do we call it a single spec exam, you need to get one from a specialist.
Sure.
Also, if I need to, I'll use the standard speculum, put it inside the vagina, gently open it, and ask them to bear down so I can see if their uterus, or if they've had a hysterectomy, if the top of the vagina is falling down. So that's the beginning of the exam.
Sure.
And after that, what I typically do is I ask them to cough, sneeze, bear down, and I examine for any leakage of urine when they cough. And if they leak a little bit of urine, we call that a positive stress test.
Okay.
So these are the people that may benefit from a procedure or surgery that you can do in the office or in the surgery center. And then these patients typically also have had their bladders completely empty. So by the time they get to the exam room, I make them cough and sneeze with an empty bladder. I stand them up. I put a dry sheet where they are standing. I make them cough. I make them bounce on their heels. We call it a heel bounce. And that's called an empty bladder stress test. If they leak with an empty bladder, then these are the patients, 85 to 90% of the time, they're the ones with the most severe type of incontinence. And none of these lasers or radiofrequency therapies or injections are likely to work. They're the ones who may need the actual sling surgery or a biologic repair, some kind of surgical repair instead of just a laser or radio wave therapy.
Because they've gone past that mark
Yeah.
of if you catch it a little bit sooner in your lifespan, then we can treat it with some radio frequency or some laser, because it's considered to be mild, right? So now they've went past that. Now it's into the either moderate to severe range, which then
Right. So those moderate to severe patients would probably benefit with a sling of some kind. A sling is a tiny piece of nylon that's about as broad as your finger and about yay long. And what it does is it acts as support for the urethra. If you think of this as your urethra is where you the tube that drains the bladder. My hand is the bladder, and my finger is the urethra. When patient coughs, there's pressure from above pushing on the bladder and forcing urine to leak out. That's the stress incontinence. And so a sling goes under here and supports this right here, so that when pressure from above comes, it does this, and it kinks this area, pushes pressure, and there's no leakage.
Right.
The leakage occurs when there's no support down here, and so the patient coughs and does this, and there's no support under it because this is all loose. So the sling is an artificial ligament to support the urethra, and that's what a sling is. And it's done in the office, typically under 15 minutes. Done in the surgery center most of the time. I do them in the office too. And the patients will stop their leakage, but sometimes that's not all. They have a fallen bladder. That's when your product is just wonderful. Your company makes VNEW dermal allograft. And for a fallen bladder, and even in certain instances, a fallen rectum, can be completely supported and mended at the same time of a sling surgery. So now you don't have this big bulge into your vagina. I tell my patients that a fallen bladder is like you're in a room and the ceiling is sagging halfway down.
Right.
And so a fallen bladder is a saggy ceiling, and you got to go and repair that ceiling, or put new supports, metal supports, and your dermal allograft is that support that lifts the ceiling up.
Yep. Yep. Absolutely. And certainly were important, with us, just because of your background, your knowledge, and all your years of expertise. And then I guess I'm trying to think. I think we've probably worked with each other for about 14 years now at this
A
point.
long time. Yeah.
A long time.
Yeah. I think you started with a company I worked with in 2002. I worked with a company called Caldera and created that sling we just mentioned called Desara.
Yep.
I helped with the design. I can't take credit for the whole thing. I just helped with the design of the hand pieces and the way it's introduced. And I think you were just starting off the company, and I was using some human dermal allografts, and now you have your own
Right.
company for that. But that's the start of it, around 2000, 2002. So we've worked together a long time.
Long time. And I'm not sure if you're aware, but we recently also launched a Fascia Lata. I think we and I were talking offline about the Hydrix product that you had helped bring to market, and then they couldn't resource the biologic anymore. And so we're getting some good feedback. And really for us, and what we try to focus on is how can we have something that's not mesh for these ladies, right? Because it's not always the best for everybody. Everyone has their own pluses and minuses about their products. So that's one of the things that we try to focus on, is how can we have regenerative medicine. And I know you are always innovating in those areas, and I think you've got some interesting things you're going to share with us in some of the courses that you are a part of coming up here. But we're going to hold that part of it, because that's a little bit of a teaser for some of the things that you're working on, which looked absolutely fantastic and just gives women more options, to help them treat their stress urinary incontinence and get themselves back on track.
Yeah, definitely. We're working on a non-mesh incontinence procedure developed in South America, and now finally with FDA approval, and we're going to be training in that in a few weeks, and we're going to bring it out to the U.S. And some of the top doctors are all training in this together. We're friends, and we can identify the trends and what's going to work.
Right.
And so we're so excited. We're going to hopefully go away from mesh products into things that are absorbable and not permanent, but give similar results.
Yeah.
Safer,
Yeah.
awake in the office. Amazing.
Yeah. So definitely, it's a great time to be a part of women's health. I think that there's been a nice resurgence in options the last few years. Certainly, I would like to think that we are a part of that, making those things happen. So if they have, did you ever have to take them down the path of urodynamics, or is it for you being able to work these ladies up? Sometimes you do, sometimes you don't. How do you make that decision?
The majority of the time, an in-office evaluation, along with, let's say, a urine culture and perhaps a simple ultrasound to see if they're retaining urine, plus my exam in the office with that half speculum, that is adequate according to the American College of OBGYN and Urologic Society. But there are cases where you're not sure whether they're leaking because of the lack of support. That's
Right.
the stress incontinence we're talking about. Or are they leaking because they're getting their bladder triggered and their bladder muscles are squeezing urine out, not having to do with coughing, sneezing, or jumping. Sometimes they're so integrated in the problem, we call them mixed incontinence,
Yep.
that we can't tell. And so when we can't tell, in my practice, it's a very small percentage, maybe 3%, where I'm completely not sure what's happening. I'll send them for what's called urodynamics. And for those of our patients who may be watching this, what's a urodynamic study? That's when we place a tiny catheter inside your bladder, and a tiny catheter, probably either in the vaginal canal or the anal canal, and it checks for pressures. And then we drip water into the bladder really slowly, a controlled drip. And as the bladder expands, we can see whether this bladder is able to hold a normal amount of urine, or is it expanding and suddenly with just a little bit of water contracting and having a spasm. So those are the goals of the urodynamic studies, to tell you, are you having a normal capacity, or are you not achieving normal capacity? Are you having spasms in your bladder? Or in some cases, people with spine disease, back injuries and things like that, they just have a way over capacity bladder, and they cannot sense that they're completely full.
Right.
So that overflow bladder, where else is it going to go? It's so full already. It's going to leak out when you cough, sneeze, and jump.
Right.
And so sometimes we have to do these studies to figure out, is it mixed? Is it overflow, or is it pure stress?
Right.
So the urodynamic study is very helpful, but we don't do as many as we used to early in my career. Everyone who had surgery had to have one, but we didn't find that it really helped the outcomes. It may help us make a good diagnosis. So it's not done as often, but I still think it has a purpose and a use for specific patients.
Yep, absolutely. So thank you for explaining that, because I know a lot of women have either been through that process, or they might have to go through that process. So it's not scary. It's just getting better data for the physician. Even though they have a pretty good idea, but everyone wants to be confident when they take them back to the OR exactly what they're dealing with. So if they're going to go through any of these treatments, what can I anticipate from a time away? What's my road to recovery? How long is this going to?
Well, let's go from the non-surgical easy treatments with no downtime all the way through surgery. You have mild stress incontinence or even overactive bladder. The treatments work good. You can get radio frequency treatments to shrink the bladder and the mid-urethra, and that will give you, like we call it, a radio frequency sling. It tightens the area and lifts it up a little bit. And for mild, sometimes moderate stress incontinence, that may be enough. Typically, it's not enough in many patients, and I have to augment it with the use of, it's called platelet-rich plasma. I take blood from the patient's arm, I spin the blood, get the growth factors, and then re-inject it at the base of the bladder or the mid-urethra. And it acts to sometimes a little bulk and support of the urethra, so that when you cough and sneeze, there's less leakage. And also that same platelet-rich plasma can often calm the bladder down. It has a nerve calming effect. Radio waves with the platelet-rich plasma, the branded term is O-shot, can both work together to reduce overactive bladder. It's pretty tremendous. I showed in a study about 2016 that with just the radio waves alone, you can reduce symptoms by between 30 and 50%. And when you add the platelet-rich plasma, that's even better. Okay, those have no downtime.
Right.
You just have your procedure and you go home. There's another therapy where you try to increase the strength of the pelvic muscles. So the injection helps with the microscopic cellular level. Mm-hmm. The radio frequency helps at the level of the skin and the tissues underneath. And then the chair that makes your muscles contract, it's called Emcella. That's one of the devices. The other one is called V-Tone. Those make the muscles themselves, not just microcellular level, not just the skin, but the actual muscles. It strengthens them so you have control, better control over your urine. So those are all non-surgical, and you can certainly have those for mild to moderate stress incontinence and even overactive bladder. And it's wonderful for mixed incontinence too, because they all work together. But let's say that didn't work. You had the series of that, or let's say most of your leakage is positive with an empty bladder. Those kind of therapies aren't going to help much if you're leaking urine with an empty bladder already, those are the ones that may need the sling that we talked about, the transobturator sling or TVT sling. We just call it sling in general. And those are typically 10 to 15-minute procedures done either in an office or a surgery center. And the downtime is 6 weeks. The patient may or may not go home with a catheter for 4 to 7 days, and it's taken off the week after. And then the recovery, if it's just a sling without a pelvic repair, the recovery is 6 weeks, and it's pretty darn comfortable. My patients can drive if they're not taking any pain medicines or narcotics. They can drive within a couple of days of having these procedures. They can't have sex for about 6 to 8 weeks, and we don't recommend any kind of heavy lifting more than, let's say, a gallon of milk. That's about as much as you can lift, and no exercises. You can't go to the gym. You can't do anything that makes you bear down, because during this 6 weeks time is when your own body fills in and grasps this sling. Think of the sling as rebar. So you're just putting in the rebar underneath the urethra, and your body provides the cement. So the cement from your body, that's collagen and elastin, fills in those gaps in the rebar, and then it supports the urethra. And that's what a sling is. For those with a fallen bladder or fallen rectum, and you're supporting it with your Fascia Lata or your dermal product, that's also rebar. You can think of it as rebar, and the patient's own cement or collagen and elastin will be the final thing that replaces that and becomes the new support for the bladder or for the rectum.
Love it. So yeah, 6 to 8 weeks. And, it's always interesting because you talk to the ladies after they come see you, A, they're very happy. And then B, they wish they would have done it sooner.
Yeah.
So that's, I guess of why I love being able to have conversations with you and be able to get the word out to these young ladies that they're going to feel so much better after they at least start addressing some of these issues that the technology has advanced so much in the last 10 years that it's not something that you as a female has to live with, right? Before it was like, welcome to 40, welcome to having babies, welcome to, it's like all these, pats on the back and saying, hey, you just kind of have to deal with it.
Another benefit of my specialty, I'm a urogynecologist, but I'm also a cosmetic gynecologist, is that when you're doing all these functional repairs, you're making everything work. You're doing you're repairing the plumbing, the electrical system, you're putting in new floorboards and all that. But us cosmetic gynecologists can also make the outside look good. It's like putting not just new paint, but restructuring, for example, will reduce the very large labia or the gaping of the opening. We do the cosmetic work too. So not only is it functional, it's also beautiful.
Right.
So function and beauty is the goal of at least my practice when I add the labiaplasty of the minora or reduction of the big saggy labia majora. I do all those together at the time of this pelvic reconstruction. You can do all of it in one sitting and one recovery so that it looks like you're back to when you were in your 20s before you had babies.
Right.
And you can make it all youthful and functional and also beautiful.
Yes, and your partner normally appreciates it too.
We talk to the partner too, so we get just the right size.
Right, and that's fantastic because you might have had an episiotomy years ago, and you've got some scar tissue, and you're not happy with it. So certainly those things you can address, which is fantastic because you're doing it all at one time. We're coming up here at the top of the hour. You've got your new practice kicked off in Dallas, right?
Yes, thank you very much. I joined Dr. Wesley Brady of the Women's Wellness Institute in Dallas, the premier feminine wellness institute. And Dr. Brady and I go back over 12 years. We've worked together. And when my kids moved to Texas, my wife and I decided we got to follow.
Right.
And so you go where your kids are. And Dr. Brady was so kind and said, Red, why don't you work out of my practice, join my practice, work 1 day, 2 days, 3 days, work 5 days if you want.
Right.
Just I want the association, and we have a good time and working together. And how could you say no to Dr. Brady? Such a kind, generous lady, and we will be taking care of not just the cosmetics. Dr. Brady's an excellent cosmetic gynecologist. She does all the labiaplasties, and she's just the best in doing this in Texas. And I'll be coming into there, bringing in my cosmetic gynecology, plus also my urogynecology, and also my hormone practice. So we'll have a practice that takes care of all the feminine needs. And so really the Women's Wellness Institute of Dallas will be a tremendous practice. Also, you may not know it, but I will also be opening a feminine wellness practice in Las Vegas, Nevada in July of 2023, and be working with Dr. Ed Zimmerman.
Oh, really?
Yeah, he's the famous Dick Doc and on TikTok, and he wants to focus on men. So he gave me a call and wanted me to start and revamp the women's section, the feminine wellness section of his practice. And I'll be going there a few days every month. And I will still be at my Irvine practice for the foreseeable future, and helping and supporting Dr. Wei as she establishes a fantastic center in Irvine, California. She's the best in Southern California in this field.
That's amazing.
Proud to be associated with these doctors.
I thought you were retiring. I thought you were slowing down.
I am. I'm just doing the stuff I like, the fun stuff that I enjoy. So for me, that's retirement.
Right. That's the best part, right? You get to pick and choose. You've worked so hard. You've raised a lovely family, and now you can kind of, say, hey, where do I want to work, and what does that look like? And congratulations on Las Vegas. Ty Erickson lives there now. I don't know if you knew that,
wow. So I thought he was still in Utah.
He commutes up to Utah. I'm going to see him next week in Utah, but he's there at Las Vegas. And, of course, he's like yourself. He's semi-retired, but busier than most people I know.
Yeah, we both like doing surgeries. Ty and I were in the same team that helped develop some of the mesh products, and so we go way back in the 2000s.
Well, I'll have to get you two connected when you're in Vegas, because he's certainly, a person that you could link up with. I know you and him go way back. So congratulations on
thank you
your opening. So what we're gonna show it on the screen. Mariel's gonna show it on the screen where you're at in Dallas, North Dallas, right?
Right. I'm in Women's Wellness Institute of Dallas. You can easily find us.
Yep, we're gonna find you there. And then Vegas is gonna open up in a month.
Yeah, it's called Aesthetic Revolution.
Okay.
And the lead doctor there is my good friend Ed Zimmerman, and I'll be working out of his office and surgery center. And in California, it's called Wei Aesthetics. That's WEI, Wei Aesthetics. And so I will have my own Alinsod Institute in all these locations.
Wonderful. Well, Dr. Alinsod, safe travels. I know you are catching a flight to the airport. I appreciate the time. So 2 things. I can't wait to hear about your innovation that you're bringing to the U.S. We're going to have to set some time on that here in the next month. And then also your hormone replacement therapy. I think women are very curious about it, because there's a lot of mixed knowledge out there, right? And so I think you could set the record straight and certainly help women in their treatment of HRT and menopause, and how to transition and still have great moods and a great quality of life.
Well, thank you for the opportunity. It's always great talking to you, and I know we have a couple of great topics in future podcasts with you. Congratulations on this wonderful, amazing training video podcast that you do. I really hope it helps all the women out there with information they need to help their needs.
Well, it's doing a great job, especially when I can have people like yourself on the show. So, thank you so much for your time.
Thank you.
Always appreciate it, and we'll see you on the next show.
Take care. Bye bye.
Bye bye.